Welcome to Board Pearls. This is episode 2 of 4 of the GI Nutrition chapter in the Special Populations and Acute or Supportive Care module. In this episode, we cover the patient whose gut cannot do the work, parenteral nutrition formulation with its chemistry-driven composition rules, the long-term complications from PNALD and IFALD to catheter infection, and short bowel syndrome with Teduglutide and its surveillance requirements. The last episode ended with the functional gut winning whenever it can. Now move to the patient whose gut cannot do the work. Parenteral nutrition is the answer when the gut is non-functional, inaccessible, or insufficient. The same operating principle holds. The gut wins when it can. Parenteral nutrition is reserved for patients who cannot use the gut at all or whose gut can supply only a fraction of the caloric need. The composition rules are where the boards test most heavily because each rule reflects a specific physical or metabolic constraint. Standard adult dosing provides 25 to 30 kilocalories per kilogram per day. Amino acids are dosed at 1:1 and 2/10 grams per kilogram. Twice weekly intravenous lipid emulsion is given in an amount sufficient to prevent essential fatty acid deficiency. The single most testable composition rule is that dextrose in parenteral nutrition provides 3 and 4/10 kilocalories per gram, not 4. Pharmaceutical dextrose exists as a monohydrate, meaning a glucose molecule plus one water molecule, so the molecular mass includes water that contributes no calories. A gram of monohydrate dextrose contains slightly less actual glucose than a gram of anhydrous dextrose. The number on the bag is real. If you calculate calories using 4 per gram, you overshoot. Amino acids contribute 4 kilocalories per gram and should be counted in total caloric delivery rather than treated as a separate protein channel because amino acid carbon enters the same metabolic pool as carbohydrate carbon. The lipid emulsion story has moved over the past decade and is worth understanding mechanistically. Lipid emulsions historically contained pure soybean oil, which is high in pro-inflammatory omega-6 fatty acids and contains phytosterols that contribute to intestinal failure-associated liver disease in long-term parenteral nutrition. Modern mixed lipid emulsions combine soybean oil, medium-chain triglycerides, olive oil, and fish oil, and it is the fish component that matters. Its omega-3 fatty acids compete with omega-6 in eicosanoid synthesis, dampening hepatic inflammation. That is the mechanism by which mixed emulsions slow IFALD progression. Pure fish oil emulsion is FDA approved for pediatric IFALD and used off-label in adult IFALD as rescue therapy. A few other composition rules follow from chemistry rather than from biology. Calcium and phosphate cannot be co-administered freely in the same solution without precipitation as calcium phosphate crystal. Compounded parenteral nutrition either uses validated solubility tables or splits the two ions across separate bags or infusion lines. Bicarbonate is not added for the same reason. Calcium carbonate also precipitates. Acetate is the buffer of choice when alkalinization is needed because acetate is metabolized to bicarbonate after infusion. Continuous parenteral nutrition runs over 24 hours. Cycled parenteral nutrition delivers the same daily caloric load over 12 to 18 hours. Cycling reduces hepatic exposure to the lipid load, lowers insulin requirement, and is associated with lower rates of cholestasis. Long-term home parenteral nutrition patients are typically transitioned to a cycled regimen for those reasons. Indication discipline matters here as much as it did for the GLIM discussion, and for the same reason. Parenteral nutrition has real risks. The indications must be real too. The good indications cluster around true intestinal failure, short bowel syndrome, motility failure, or multiple enterocutaneous fistulas, severe acute pancreatitis intolerant of enteral feeding, prolonged ileus exceeding 7 days, bone marrow transplant mucositis preventing oral or enteral intake, and high-output stomas with refractory dehydration despite oral rehydration. The bad uses are the more testable ones. Parenteral nutrition is contraindicated or harmful in metastatic cancer cachexia, where the catabolic-driven weight loss is not reversed by caloric supplementation, and central catheter risks add infection without survival benefit. Parenteral nutrition is inferior to enteral feeding in mild to moderate acute pancreatitis, where randomized trials have shown lower infection rates and lower mortality with the enteral route, and in inflammatory bowel disease Enteral and parenteral routes produce equivalent outcomes, so the lower-risk enteral route is preferred. The recurring point is that parenteral nutrition is a tool for non-functional gut. It is not a tool for low albumin and not a tool for cachexia. The long-term complications of parenteral nutrition follow predictable mechanisms, and the recognition stems on the boards turn on knowing those mechanisms. Start with the gallbladder. Parenteral nutrition-associated cholelithiasis develops in roughly half of long-term parenteral nutrition patients through a single mechanism. Sustained NPO status produces gallbladder stasis without CCK-driven contraction, and the stagnant bile cholesterol crystallizes into sludge and stones. The intervention is small. Even enteral feeding at 20 to 30% of caloric needs restores duodenal CCK release and reduces stasis dramatically. The lesson is that the gut deserves whatever stimulation it can tolerate, even when parenteral nutrition is doing most of the work. Intestinal failure-associated liver disease, written as IFALD and sometimes called PNALD for parenteral nutrition-associated liver disease, progresses from steatosis to cholestasis to fibrosis and can produce end-stage liver disease in patients on long-term parenteral nutrition. Multiple mechanisms contribute. Lipid emulsion type matters. The historical pure soybean oil emulsions are worse than the modern mixed emulsions. Recurrent septic episodes accelerate the injury. Lack of enteral stimulation contributes. Manganese accumulation contributes. Choline deficiency contributes. Management is therefore multimodal. Switch to a mixed lipid emulsion. Minimize the lipid dose. Treat sepsis aggressively when it occurs. Advance enteral feeding wherever tolerated. Transition to a cycled regimen. Refer for intestinal transplantation when liver failure is established and the rehabilitation strategies have run out. Manganese deserves its own mention because the mechanism is testable and clean. Manganese accumulates in the basal ganglia of long-term parenteral nutrition patients because biliary excretion, the normal disposal route, is impaired by cholestasis, and the intravenous route bypasses the gut barrier that normally limits manganese absorption. T1-weighted MRI shows hyperintensity in the globus pallidus, and Parkinsonian signs can emerge with chronic exposure. Manganese is removed from parenteral nutrition formulations once cholestasis develops or once T1 signal change is detected. The pattern is Parkinsonism in a long-term parenteral nutrition patient with cholestasis and globus pallidus T1 hyperintensity. The response is to remove manganese from the formulation. Catheter-related bloodstream infection runs at roughly 1 to 2 episodes per 1,000 catheter days in experienced home parenteral nutrition programs and is the leading cause of hospitalization in this population. The mechanism is biofilm formation on the catheter lumen by skin and oral flora introduced at catheter access. Coagulase-negative staphylococci, Staphylococcus aureus, and Candida species predominate. Salvage of the catheter, rather than replacement, is attempted with systemic antibiotics plus catheter lock therapy when the organism is amenable. Ethanol catheter lock and taurolidine catheter lock therapy reduce recurrent infection in patients with multiple prior episodes. Ethanol works by disrupting the biofilm matrix. Taurolidine combines antimicrobial and antibiofilm activity. That brings us to the patient who is the dominant indication for long-term parenteral nutrition, which is short bowel syndrome. SBS follows extensive small bowel resection, conventionally meaning less than 200 centimeters of remaining small bowel, and the functional consequences are determined by the anatomy of what remains. The teaching here is anatomic, because the prognosis and the complication pattern diverge sharply by phenotype. 3 anatomic phenotypes organize the rest. Angiogynostomy, meaning no colon in continuity, is the worst prognosis. Stomal output runs about 100 milliliters per centimeter of remaining bowel per day. Hypomagnesemia and dehydration are chronic problems because the colon, the major site of fluid and electrolyte salvage, is absent. Patients with less than 100 centimeters of remaining jejunum almost always require permanent parenteral nutrition. Jejunocolic anatomy, meaning some small bowel plus colon in continuity but no ileocecal valve, benefits from colonic salvage of fluid, sodium, and short-chain fatty acids generated from bacterial fermentation of unabsorbed carbohydrate. Patients with at least 60 to 90 centimeters of small bowel plus retained colon often achieve enteral autonomy. Jejunoileocolic anatomy, with an intact ileocecal valve plus colon, adapts best. The ileocecal valve slows transit and gives the residual bowel more contact time for absorption, and it also prevents retrograde colonic bacterial colonization of the small bowel. Ileal length itself is critical. The terminal ileum is the only site of bile acid and B12 absorption, and ileal loss produces bile acid malabsorption, diarrhea, and B12 deficiency that no amount of proximal small bowel can compensate for. Medical management runs in 3 domains: caloric support, fluid and electrolyte balance, and intestinal adaptation. Adaptive hyperphagia, meaning eating 1.5 to 2 times the calculated caloric need, compensates for malabsorption and is encouraged where the patient can do it. Oral rehydration solutions match to small bowel sodium glucose cotransport drive net water absorption through the SGLT1 transporter. The composition is sodium 90 milliequivalents per liter and glucose 90 to 110 millimoles per liter, because SGLT1 obligates 1 water molecule across the apical membrane for every sodium-glucose pair transported. Plain water fails. Most sports drinks fail. Their sodium and glucose concentrations are below the SGLT1 stoichiometry, so they produce net water loss into the lumen rather than net absorption. That is the mechanism worth carrying. The rehydration solution is engineered to match a specific transporter's substrate ratio. Antimotility agents reduce stomal output by slowing small bowel transit. Locaamide, diphenoxylate atropine, and in selected patients codeine are the standard agents. High-dose proton pump inhibitors reduce gastric hypersecretion that follows extensive small bowel resection. The gastrin-driven hypersecretion is mediated by loss of jejunal, CCK, and other inhibitory hormones. The PPI suppresses the acid output that would otherwise overwhelm what little absorptive surface remains. Cholestyramine has a narrow window of use. It is reserved for the 30 to 100 centimeter ileal resection phenotype, where bile acid malabsorption produces colonic secretory diarrhea. Cholestyramine is avoided when ileal resection exceeds 100 centimeters, because at that resection length, the bile acid pool itself is depleted, and binding the dwindling pool with cholestyramine worsens the steatorrhea. So the rule is mechanism-driven on both ends. You give cholestyramine when there is excess bile acid reaching the colon, and you withhold it when the pool itself has collapsed. Pancreatic enzyme replacement is added when concurrent pancreatic insufficiency contributes to maldigestion. Teduglutide is the GLP-2 analog that changed long-term management of CPN-dependent SBS. GLP-2 is a trophic hormone produced by L cells of the distal small bowel and colon. The drug increases villus height, slows gastric and intestinal transit, and reduces parenteral nutrition volume requirements in adults with parenteral nutrition-dependent SBS. Randomized trials showed that roughly 60% of treated patients achieved at least a 20% reduction in weekly parenteral nutrition volume, with a meaningful subset weaning off parenteral nutrition entirely. The trophic effect is the reason the drug works, and the trophic effect is also the reason it has surveillance requirements. Baseline colonoscopy with polyp removal is required within 6 months before initiation. A follow-up colonoscopy is performed at the end of year 1. Surveillance colonoscopy is then repeated every 5 years because the trophic effect of GLP-2 raises theoretical concern about colorectal polyp growth. The surveillance is precautionary. The absolute colorectal cancer incidence in trial patients was not elevated. Active GI malignancy is a contraindication because the same trophic effect that helps the residual gut could accelerate tumor growth. The drug's mechanism predicts both the indication and the surveillance, and that pairing is the teachable shape. 2 SBS-specific metabolic complications round out this episode, both of them colon-retaining problems. Enteric hyperoxaluria with calcium oxalate kidney stones develops in colon-retaining SBS patients through a specific mechanism. In the normal small bowel, dietary calcium binds oxalate in the gut lumen, and the calcium oxalate complex is excreted in feces. In SBS with fat malabsorption, unabsorbed long-chain fatty acids preferentially bind calcium as calcium soaps, which leaves free oxalate in the lumen for the colon to absorb. The absorbed oxalate is filtered by the kidney and precipitates as calcium oxalate stones. Prevention is a low oxalate diet, avoiding spinach, rhubarb, beets, nuts, and chocolate, plus oral calcium supplements timed with meals to bind dietary oxalate before it reaches the colon. Enterostomy patients without colon do not develop enteric hyperoxaluria because the absent colon cannot absorb oxalate. The presence or absence of the colon is the discriminator. D-lactic acidosis is the second colon-retaining complication, and the one that masquerades as a metabolic puzzle. Carbohydrate that escapes small bowel absorption reaches the colon, where lactobacilli ferment it into both L-lactate and D-lactate. Human metabolism handles L-lactate, but only slowly metabolizes D-lactate, which accumulates and produces neurologic symptoms including slurred speech, ataxia, and confusion, with a high anion gap metabolic acidosis. The clue at the bedside is intermittent encephalopathy and a colon-retaining SBS patient whose standard L-lactate is normal and whose anion gap is unexplained until D-lactate is sent specifically. Standard lactate assays measure L-lactate only, and that is why the workup misses it. Treatment is carbohydrate restriction plus oral metronidazole or neomycin to suppress the lactobacilli population. The recognition is the teaching. SBS, neurologic episodes, anion gap unexplained by a normal lactate level, send D-lactate. Pull the parenteral and short bowel half together. Parenteral nutrition is a tool for non-functional gut, with composition rules that follow from chemistry, the 3.4 calorie dextrose, and the calcium phosphate precipitation being the sharpest, and indication discipline that follows from trial data. Its long-term complications are driven by the loss of enteral stimulation, cholelithiasis from gallbladder stasis, IFALD from soybean oil emulsions and sepsis, manganese Parkinsonism from impaired biliary excretion, and catheter biofilm infection. And short bowel syndrome turns on residual anatomy, with the colon's presence or absence determining both the rehabilitation trajectory and the complication pattern, while Teduglutide's trophic effect explains both its efficacy and its surveillance burden. The next episode takes the same framework into the micronutrients themselves, beginning with the vitamins. The fat-soluble vitamins A, D, E, and K each produce a specific phenotype through a specific mechanism, and the water-soluble vitamins carry the recognition stems the boards favor, thiamine for Wernicke, and B12 versus folate for the megaloblastic anemias. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 2 of 4 of chapter 32, and I'll see you in the next one.